Hello everyone, how are you all? Hope you all are doing good. So welcome back to another session of random MCQ discussion. So I hope you can see the screen and hear me before we start. Can somebody please confirm? Okay, thank you very much for that. All right, so let's start discussing the questions for today's session. We have some selected questions for today's session as well. So I hope you know the drill. So we'll be discussing the questions. And I'll be giving you some time to come up with the answers, and then I'll be leading you towards the discussion. All right. So as I've told previously also, the questions are not complete. They are as it is as we received, but we are going to have a fruitful discussion with what we have. All right. So this is the first question for today. Elderly man with cough and SOB, that is shortness of breath, was a construction worker at a tunnel company. Chest X-ray given of a left-sided effusion. The fluid in the chest was noted to be bloody. What is the cause? Answer 1, mesothelioma. 2, carcinoma of the lung. 3, sarcoidosis. So what do you guys think? What should be the answer here? Okay, I'll give you some more time to come up with the answers. I can see that most of you are voting towards 1 and 2. That would be mesothelioma and carcinoma of the lung. Okay, we'll see what the others think. All right, so most of you think the answer should be either 1 or 2. 1 is mesothelioma, 2 is carcinoma lung, and there are a few who thinks it should be sarcoidosis. All right, so let's see what do we have here. We have an elderly man. As I've always told you, the age is important. We have an elderly man with cough and shortness of breath. And he was a construction worker at a tunnel company. And chest X-ray given of a left-sided effusion. Fluid in the chest was noted to be bloody. Okay. So what is the cause? So here, this question asks you, test your knowledge on hemorrhagic pleural effusion, causes for hemorrhagic pleural effusion, and checks whether you know how to work out the cause of the hemorrhagic pleural effusion based on the history given. So before we start off with that question, now you should know the causes for hemorrhagic pleural effusion or bloody fluid trained on pleural effusion. So it could be a malignancy, connective tissue diseases, and asbestos exposure causing benign disease or malignant mesothelioma, and pleuropulmonary infections, connective tissue diseases, cardiovascular condition, bleeding diseases. Though these are like umbrella terms, there are some different etiologies which you can leisurely go through, but commonly you should know it is the pleural malignancies and the malignant mesotheliomas, and some infections, especially like tuberculosis and all, can cause hemorrhagic pleural effusion. Okay, having said that, let's move on to our case. So here we have an elderly man with a hemorrhagic pleural effusion. So for answers, we have mesothelioma and carcinoma of the lung. So both of which are well-known causes for hemorrhagic pleural effusions. Well, when it comes to sarcoidosis, it can also cause hemorrhagic pleural effusion. Not a very common cause, but it can also cause hemorrhagic pleural effusion. So we'll keep this aside, though it can also cause this. All right, so now let's see how to work out which of this is the correct answer. All right, can somebody mention the most important thing in this MCQ that will lead us to the answer? There is the most important clue in this MCQ that will lead us to the answer. Very good. Excellent. Working in a tunnel. So that is the clue that you're going to look at to come out with an answer. So he's working in a tunnel, some sort of a thing, and he's a construction worker. So his occupation is very important here because this shows us the risk factor. So being a construction worker makes us think a little bit more towards an asbestosis exposure, and that would lead to a mesothelioma, which is a malignant condition resulting from asbestosis exposure. So based on this occupation, we can lean a bit towards mesothelioma in this case. Now, some of you might think of carcinoma lung because of this age, elderly. So you might have thought of that. And but when you take this occupation, which is like a clear clue that has been given, you have to consider mesothelioma first. Even that's a malignant condition. Mesothelioma is the most logical answer here. So the answer would be answer 1. Okay. All right. So the next question. 2-year-old comes with a 2-week history or so of cough and wheeze. Started when the child was playing. Symptoms didn't respond to antibiotics and nebulization. What is the initial investigation? 1, chest X-ray, 2, CT scan. Now, okay, now, sorry. Okay, this one. Okay, now this might seem as a very easy question. Even without knowing the theory and the content that is being tested, you might come up with the answer because it seems very easy. But there are some few things that needs to be discussed here. So let's see. What do you guys think? I'm sure that all of you will answer the correct one. Okay, all right. So most of you think we should go with the chest X-ray, which is actually very correct. All right, I can see someone has actually mentioned the reason also, chest X-ray to rule out the foreign body. Very good, excellent. So that's what we are going to do here. Now here you have a 2-year-old child coming with a 2-week history of cough and wheeze. And this has been started when the child was playing. And the symptoms didn't respond to antibiotics and the nebulization. So what is the initial investigation? So what makes you think of a foreign body here? Can somebody mention? What thing makes you think of a foreign body here? Very good. Dr. Ayman, I think, very good. So this has started when the child was playing. All right. So there is something in this history that doesn't fit in this case. Can anybody spot it out? Now, the symptoms have started when the child was playing. So this made us think of a foreign body here. And this has not responded with the antibiotics. Very good, very good. Somebody has mentioned. So both of those 2 factors make us think of a foreign body, which has, yes, very good, excellent. I think I couldn't see the name. Very good. So my next question was also answered. So what I was telling was, now here, these symptoms have started when the child was playing and it didn't respond to antibiotics and nebulization. So whenever a child comes with wheezing and that has started with playing or some sort of a thing and not respond to nebulization, you have to always think of a foreign body. So this has been repeated previously as well in a different way. But my next question, what is not fitting is the duration. You all have spotted it very correctly. Now this can't be 2 weeks, right? It can be, but then the foreign body should not be causing much trouble. So usually this comes as an acute history when there is a foreign body. So maybe this is not fitting very well, but that's all right because we have to look at the general picture. Now here this child has developed this cough and wheeze when he was playing. So he might have inhaled something or he might have ingested something that has gone into his respiratory system, which has been causing this cough and wheeze. We are not sure. So, and it has not responded to antibiotics. So we have to rule out a foreign body here. So our initial investigation would be a chest X-ray, that is to rule out a foreign body. Okay, now this question might have been complicated with some more answers, though it has been given only 2 here. 3, 4, 5, you would have had some other answers that might confuse you. Now, CET, obviously, you won't think as the first investigation. So that's why I told previously also, you can easily put the answer here even without knowing the theory behind the question. CET, you will never be doing as a first investigation in this sort of a case, but there might have been other answers which might confuse you. What you have to understand is, you have to always suspect a foreign body, especially in a child with the history of this sort. Okay, so I hope that was clear. All right, moving on. Next question. Diabetes mellitus, 10-year-old child. HbA1c 15%. Child reports that glucometers at home ranged to 5 to 9. What could be happening? So this had been the question. Okay, what do you think? 1, child reported wrong reading. 2, wrong HbA1c report. 3, her strips might have expired. So what do you think? This is also a very good question, which we can discuss a lot. I'll give you some time for this. Actually, it's nice to see all of you voting the answers and interacting, because that makes a lot of sense and a lot of enthusiasm and interaction, which keeps this discussion going. All right, you can go on voting. I'm just going through the answers. I can see most of you think the answers are 1, child reported wrong readings. 2, wrong HbA1c report. 3, her strips might have expired. Okay, most of you think it's her strips might have expired. Oh, answer 3. And some of you think it should be child reported wrong readings. Answer 1. Answer 2, wrong HbA1c report. There were a few who thought of a wrong HbA1c report. Okay, so let's see here what's happening. All right, so you all are going to come up with the answers here as well. We'll see. Now we have a 10-year-old child with an HbA1c which is 15, which is obviously very high. Now, but the child says the home glucometers were ranging from 5 to 9, which is not a very high value, which is nothing to worry actually. So what could be happening? So let's say child reported wrong readings. That can be a cause, because when the child reported wrong readings, sometimes then this scenario can fit. Wrong HbA1c report, yeah, even that could be a cause, because now we have one report here and we were not told whether it was repeated or anything as such. So it could be a wrong HbA1c report also. Her strips might have expired. Okay, even that is possible, because expired strips can give rise to wrong readings. So that we all know. So even that is possible. So now we are in a dilemma of which is the correct answer. All right. Now, in the original exam, you would have a lot of other information to make you think towards one answer, which will point you towards one answer. It would not be this difficult. But here, let's see how to work out with the information that we have, with this limited information. All right. So most of you are thinking strips might have expired. Okay. So why not? Now let's go with answer 1 and 3 here. Why not answer 1? Why do you lean more towards answer 3 than answer 1? Can anybody mention? Now let's keep the report apart. Let's first think of the child's end. Child reported wrong readings. Her strips might have expired. So yeah, most of you have thought of strips might have been expired. Why not answer 1? What made you think of that? One thing is, yeah, 10-year-old child. So child is not a very small one. So the child can mention the numbers correctly, can read the numbers correctly. Very good. The age is a very important factor here. If this would have been a very small aged one, then you would have thought of something else. Okay, so there are very good dancers coming up actually. So he's a 10-year-old with type 1 diabetes, so well experienced. Very good. That is another cause because he would have been reading a lot. And there's a very important answer. There's a gap between 5 and 9. If they reported wrong, maybe similar numbers. Yeah. So there are. Okay, so that is one thing. So those answers are correct. And another thing is, as doctors, we should not first go with finding faults in a patient. So that's the important thing that I wanted to highlight here. So first, we should check the other options, and then only we are thinking of some like wrong behavior or faulty behavior of a patient. So actually, we should first consider this option. We should not be first going and thinking of the child reporting wrong readings. We can't now when the think of this as an actual scenario. So when the child comes to you, you are not going to tell, okay, you are reporting wrong readings. That is wrong. So this is the correct report. Your control is poor. We are not going to do like that. First, we are going to check whether the strips are expired. So we are going to go with that option first before pointing the finger to the child. Okay, so first we are going to see whether the strips have expired. If the strips are not expired, then we are coming to the other two options, whether the reported readings were wrong or whether our HbA1c report was correct. So for this one, we can check by checking whether there was a parent supervision before the child reported the reading, and whether we can check the glucometer, and we can do one instantaneously and ask the child to report the reading, check how the child is checking, which will tell us whether the child was doing it correctly. And we can do some sort of a things to rule out one. And then finally, we are going with our HbA1c report to check whether it's wrong or correct. Because checking whether it's wrong or correct needs it to be repeated again, which will cost money. So that should be our last resort when we have some other options that we can rule out free of charge and without before coming to a conclusion. So based on that factors, we can think of this answer 3 as the answer here. But here, I agree, all three are possibilities. All three can cause to discrepancy in this HbA1c reading. So in the original exam, you will have more information that will actually tell you, give you some clue to select the correct answer. So don't worry about it too much. Based on these factors, we are selecting answer 3. But if you have more information, that will definitely lead you to select one of the answers from these three without any doubt. So what I wanted to tell is, first you are not going to point fingers at the patient as the first step. First step should be ruling out the other options that are like possible, and then you are going to check for the other options. I hope I was clear. If it's not clear, please let me know. All right, next question. Before that, okay, there are some questions. Yes. Very good. There is another option. Will the patient be okay with an HbA1c of 15? Yeah. So before going to the report error, we have to check that as well. So that's a very good observation. And there's a question. Expired strips may show too high or too low. Sorry. If the machine is expired, there won't be any reading. Or no, it's not always like that. They might show wrong readings as well. Okay, so I hope I answered the questions there. Let's move on. Young male recently working as a vet assistant at an animal surgery presented with purulent discharging cervical lymphadenopathy and fever and generally unwell. What to do next to aid diagnosis? So this is also a bit easy one. Let's see. Okay, there. Yes, answer for the previous question is 3. We don't blame child without any behavioral history. Yes, very good. So we don't blame the patient before we rule out the other things. So that's the important message that I wanted to highlight in the previous question. Okay, so here let's see. We have answer 1, pus swab, answer 2, serology for Bartonellosis. Okay, so let's see here. Most of you think we should go with pus swab, which is answer 1. But there are few who think we should go for answer 2, that is serology for Bartonellosis. All right, let's see. Now we have a young male recently working as a vet assistant, that is working with the animals, at an animal surgery presented with purulent discharging cervical lymphadenopathy. Okay, fever and generally unwell. What to do next to aid diagnosis? So when you have this sort of a question, now here he always, I have told you previously as well, look at the last sentence. So what they're asking what to do next. They're asking the next investigation to aid diagnosis. So you have two things here. You have to answer with an investigation, but that should aid you in the diagnosis as well. So when you have a question like this, when you need the investigation, first you have to find out the diagnosis here, or most possible diagnosis here, and then you can easily work out the investigation. So when to figure out the diagnosis here, you should look at the clinical syndrome as a whole. So here you have a patient with fever and cervical lymphadenopathy, and generally unwell means some sort of a systemic disorder is going on. So that tells you that with the fever. So fever and cervical lymphadenopathy, which is purulent discharging cervical lymphadenopathy. So that is your clinical syndrome. And so you have to, so what are the possible diagnoses here? One could be actually, yeah, it could be an abscess. Abscess which has been formed, which has caused fever and with purulent discharging lymphadenopathy. But an abscess will not cause generalized cervical lymphadenopathy. It will usually be a localized one. But still, they have not mentioned how many nodes, cervical nodes have in play. So yeah, it could be a possibility. The next thing, like you all have voted, Bartonellosis or your well-known cat scratch disease. So that is another possibility, because in cat scratch disease, you get fever with purulent discharging cervical lymphadenopathy. That is like the pathognomonic feature of it, feature in Bartonellosis. So that is another thing. And another thing that could be, yeah, actually the infection is like the most common cause because of the fever. So thinking of that, now we have to now pus swab. When we look at the answers, we have pus swab and the serology for Bartonellosis. Okay. Now we have two possible answers. Either it's an abscess caused by some sort of an infection, or whether it's cat scratch disease. Now, what will aid us in the diagnosis, like in the previous question, would be this occupation. So he is a vet assistant at the animal surgery. So this occupation makes him more likely to have a cat scratch disease. So this again points out that the occupational history is very important, especially when doing this sort of an MCQs. They, in your original exam, they will usually give a good history with occupational history as well. So always pay attention to that. So he's a vet assistant. So that makes us think more towards cat scratch disease or Bartonellosis. So then we can think of Bartonellosis as the most possible diagnosis here. So what are we going to do the diagnosis? So how do we diagnose Bartonellosis? Is it through serology or is it through pus swab? For that, you need the theory behind Bartonellosis or cat scratch disease. All right, so here, let me take you to the diagnosis part of cat scratch disease or Bartonellosis. Now, this cat scratch disease is also a very common area that has been being tested. So it has been tested in a different way previously. The pus discharging axillary nodes were given and asked for diagnosis. So here it has been given as a history. You can get it as an imaging as well. So here, this is how do you diagnose it? you usually do the diagnosis by serological testing actually. So serology is considered as the most like the common or the most accurate one to diagnose Bartonellosis. Now you have a very good account here, but when it comes to biopsy, what you have here is lymph node biopsy is generally not indicated actually. So it's usually the serology and the CT and other histological things that you can consider when you have to find out other complications also. Okay, so here this gives a nice approach on diagnosis of Bartonellosis, but what you have to understand is it's usually the serology that we use. Okay, so when we go to our case, we have serology for Bartonellosis and first off. Now it's very clear for us that we will go with answer 2, which is serology. Now pus swab we don't need because we are not going to check the organism as such here. Now if it had been an abscess, maybe we can get the pus swab to guide us in the in fine tuning of our antibiotic. Actually, it's not for the diagnosis, it's for us to fine tune the antibiotic in an abscess. So even if you think of that, it's wrong. So here, this case is a very clear-cut case of Bartonellosis or cat scratch disease, and you are going to diagnose it with serology. So the answer, what to do next to a diagnosis would be answer 2. Okay, I hope it was clear how to get that answer. Okay, next one. Man presents with central chest pain that radiates to back. On transit to hospital, his blood pressure was elevated and tachycardia. On arrival, he became unresponsive, pulseless and cyanosed. Has distended neck veins and ECG showed non-specific ST and T wave abnormalities. What is the diagnosis? 1. Cardiac tamponade. 2. Rupture of descending aorta. 3. Supraventricular congestion. So what do you think? Sorry. Okay, so while you come up with the answers here, I will address the questions that have come from previous question. I hope you will highlight or circle the answer. Okay, you can't understand. All right. So I'll circle the answer in the end. Madam, in cat scratch disease, discharge is only from the site of cat scratch. No, it's not like that. In cat scratch disease, at the site of the cat scratch, you will get a wound and you will get like a small papular lesion as such. It's like a small papular like a lesion will appear at the site of cat scratch. But lymphadenopathy, cervical lymphadenopathy will be there. And this lymphadenopathy will be like purulently discharging lymphadenopathy. So the lymph nodes will swell and they will discharge purulent discharges. So that is a different thing. At the site of cat scratch, you will get a papular lesion. It will actually heal with time. Okay, so the lymphadenopathy will be a separate thing in cat scratch disease. Okay. All right. Okay, so let's see. Here, most of you have, there is a difference in the answers, answer 1 and 2. Okay, let's see. I'll highlight the answer in the end. Okay, that's all right. Now here you have, for this question, let's see. Okay. All right, so most of you think towards answer 1 and 2. Okay, let's go through the question. Here we have a man presenting with central chest pain that is radiating to back. So this history, central chest pain radiating to back is important. On transit to hospital, his blood pressure was elevated and tachycardia had been there. On arrival, he became unresponsive, pulseless and cyanosed. Had distended neck veins, and ECG showed non-specific ST and T wave abnormalities. Now he is having a central chest pain that has been radiating to the back. So when you have a central chest pain radiating to back, the two most common things that comes to our mind are, one should be an aortic dissection and the other one would be a sort of a pancreatitis. But this seems as an acute history. So aortic dissection on the top and then maybe pancreatitis, let's keep aside because it also fits to the chest pain radiating to the back, but it's usually an upper epigastric pain. But anyway, let's keep it aside. On transit to hospital, his blood pressure was elevated and tachycardia. So he had been having hypertension with tachycardia. So that now when we take our first initial working diagnosis was an aortic dissection. Yeah, you can get hypertension with aortic dissection. That is a very common presenting feature. And on arrival, he became unresponsive, pulseless, and cyanosed. So now his condition has worsened. He has become unresponsive, pulseless, and cyanosed. So that is very important. So his pulses have dropped and cyanosed. They have not mentioned which pulse, but pulseless is there. Then he has had distended neck veins and ECG showed non-specific ST and T wave abnormalities. Okay, so now when we go through the answers, we have cardiac tamponade, rupture of descending aorta, supraventricular congestion. Now, supraventricular congestion is out. Nobody has voted for that as well because it's not fitting to this diagnosis. You will not have this sort of a picture in a supraventricular congestion. It's not a very common condition as well. Then we have cardiac tamponade and rupture of descending aorta. So cardiac tamponade, you get your Beck's triad. I think all of you know that. You get elevated JVP, muffled heart sounds, and hypotension. So having hypertension is very unlikely in cardiac tamponade, but here distended neck veins are there, which is one part of the Beck's triad. But the rest of the picture is not fitting to cardiac tamponade. In cardiac tamponade, you can get a chest pain, though it's usually not radiating to the back. You can get a chest pain, but you usually get Beck's triad, which is hypotension, muffled heart sound, and elevated JVP. So what about the next answer? Rupture of descending aorta. Now we were talking about an aortic dissection here. So central chest pain radiating to back, then with high blood pressure and tachycardia. Then this dissection, it's extending and becoming more bigger and bigger, causing a rupture or dissection itself. So the patient is becoming unresponsive. Now, because of this, the blood supply to the distal region has been cut off. So he's becoming pulseless and cyanosed. And there's a congestion or there's a block. So distended neck veins is there. And ECG is showing non-specific ST and T wave abnormalities. So all of this fits to answer 2, which is rupture of descending aorta. All right. So here the correct answer should be answer 2, that is rupture of descending aorta. So I have highlighted it. So this should be the correct answer. So let me take you to the diagnosis of aortic dissection. Actually, ECG, when you take ECG, you will not have you can't diagnose aortic dissection with an ECG. You will have non-specific ST and T wave changes, which I have highlighted here. Okay. Now, it's usually when we take the imaging techniques, chest X-ray is like the initial imaging things that we used. Okay. We are not using ECG to diagnose an aortic dissection, but ECG will show non-specific ST and T wave abnormalities. So it's usually a chest X-ray that we use, and then after this being done as initial, then we are going for CT angio, and other sort of investigations. All right. Okay. All right. Now let's move on to the next question. Picture of a penis. Patient used to live in shared accommodation. Itchy wrists and hands. Answers A, scabies, B, lymphogranuloma venerea. What do you think? Okay, so while you answer, you can go keep on answering these. I'll check whether I have missed any question in the previous ones. ECG and CT show low voltage QRS and electrical alternate. Yes, correct. Ascending aorta can lead to cardiac tamponade. Yes. No questions. Dissection can lead to tamponade. Yes, very correct. Aortic dissection can lead to tamponade, but here your diagnosis is not going to be tamponade itself because it will not explain all the other symptoms that the patient had. Tamponade is a complication here. So here the clinical diagnosis is aortic dissection because it can explain the entire clinical scenario. It might have caused the complication of cardiac tamponade. So that's not the cardiac tamponade is not the answer here. It's the aortic dissection which can explain the entire scenario. So you are not going to answer cardiac tamponade because it can be a complication here. It's not like the entire clinical picture. I hope it was clear. All right. So, all right. So here most of you think it's scabies. Actually, it's very correct. So you have a picture of a penis. Patient used to live in shared accommodation. Itchy wrists and hands. So picture of a penis, actually it's not mentioned what had been shown. Think of it as a rash or some sort of a penis disorder had been given. And so when you take the two answers, scabies can cause lesion in the penis. Lymphogranuloma venereum can also cause lesion in the penis. So patient used to live in shared accommodation, which is a clue for us to come to diagnosis. And itchy wrists and hands is the very important clue here. Because in scabies, you usually get burrows of these scabies happening in your wrists and in the hands. So that can give rise to this itchy wrists and hands. But in lymphogranuloma venereum, you don't get such sort of a picture. So here the correct answer should be answer A, which is scabies. Okay, so let me take you to the resource material for you that will give you an understanding about scabies and the lymphogranuloma venereum. So here this, I hope you can, it's still loading. Okay. So this is the latest one, the scabies one. So here you will have the clinical features. Now this is what I wanted to show. Here you can see that papular rash in the wrist, especially you can also see burrows that will give to itchy wrists and hands. Okay, now this gives a nice overview of the scabies diagnosis and treatment as well. It's only a 2 to 3 page article, which I would recommend you to go through because the next time you can get a question on management of scabies as well. So it's wise to have an understanding about that. Then the next thing would be your lymphogranuloma venereum. Okay, so what will happen there? Here you will usually get a lesion in your penile region. So this, I know all of you must be familiar with this now, Australian STI management guideline. You can learn about every STI and the guideline for every STI management could be found here. So here, the clinical presentation of lymphogranuloma venereum, it could be primary, secondary or tertiary. It's usually a small ulcer or nodule on the penis, and they can also have proctitis and lymphadenopathy inguinofemoral. Nothing sort of happening in the hands or face. It's not common to have something like that. So this you can go through. It's also a very small article which gives you like small guideline which gives you an overview of lymphogranuloma venereum diagnosis and management. This actually gives you the management of all the STI management guidelines. Okay, so that's just show you that. So here the answer is answer A, which is scabies. Next one, patient presents with silvery scaly lesions around her elbows, already given hydrocortisone, but no response. Next, A. Coal tar, B. Methylprednisolone, C. Calcipotriol, D. Acid binding resins. Okay, there's a question. While you answer this, I'll address the other questions from the previous one. Where is the article? Actually, this is I hope you're asking about the previous one. That is actually the STI one is the STI management guideline. Scabies one is an RACGP, which is your recommended like reading material actually, which gives you like overview of different conditions. When I share this note, I will send you that link as well with the note, so you can go through that. Okay, so here what do you think? Coal tar or calcipotriol or methylprednisolone or acid binding resin? Okay, so most of you think it's answer A, which is coal tar. Some of you think it's answer C, calcipotriol. And there are a few who thinks this is, we should give methylprednisolone. Okay, so this I can see the diagnosis you all have mentioned is actually psoriasis. Very correct. The diagnosis is psoriasis because you get silvery scaly lesions. When you hear this word silvery scaly lesion, the first thing that should come to your mind is psoriasis. So this patient is coming with this, and it's usually there in the elbows, which is the flexural region. And they have already given hydrocortisone, no response. So this question tests your knowledge on management of psoriasis. So let's go through this again an RACGP1 guideline on how to like diagnose, manage everything about psoriasis. Let's see. All right, so here, okay, so here you have the history, examination, everything diagnosed. This is the silvery scaly lesion that we've been talking about, okay? So elbow psoriasis and ear and everywhere. So you can see this. And then this gives you a nice overview of like different forms of psoriasis. It's wise to go through these pictures as well, because usually in dermatology questions, sometimes you will get pictures to identify the disease, diagnose the disease, and then come to a management. So I would highly recommend you to go through these pictures and to understand how to identify psoriasis through pictures. Okay, so when it comes to treatments, it's usually the topical steroids that we give as the mainstay. So like in our case, hydrocortisone has been given in our case, but it's usually the topical steroids as the main line of treatment. So if a patient is not responding to that, then we are going to go with systemic treatments. So the systemic treatments would usually be these: ultraviolet light therapy, methotrexate, cyclosporin, neostigazine, and biologics. Okay, these are like the systemic treatment options available. Of course, they have risks. We should educate the patient on that. And then we are going to go ahead with this. And there are some specific treatments as well. So your specific treatments would be this calcipotriol cream, and then diethanol plus salicylic acid or emulsifying ointment, then your tar cream actually, and then you have for face and flexures, you can have some different options. You can go through this later. Then for scalp psoriasis, you have a different thing. For nail psoriasis, you have a different thing. So that's it about the management. So calcipotriol and tar belongs to this specific treatments. So this is like the overview of psoriasis treatment. I hope it was clear. So we'll go back to our question. You can go through this link leisurely and have an idea of psoriasis diagnosis and management. So when we come to our question, when we go through the answers, we have coal tar, Methylprednisolone, of course, is not an answer here because it doesn't belong to systemic or specific therapy. Calcipotriol, yes, it's a specific therapy. Acid binding resins out. So out of Colta and calcipotriol, which is best? Now here comes the confusion. So whether it's Colta or calcipotriol. Now usually it's a tar cream that is being recommended nowadays. Yeah, Colta is also all right. So when we take Colta and calcipotriol, now evidence suggests more towards using calcipotriol. The efficiency or efficacy of the calcipotriol seems to be more than Colta. So calcipotriol is preferred than Colta according to many research evidences and latest evidences. So you should choose calcipotriol over Colta in such cases because both are there. So here the correct answer would be answer C, which is, wait, I'll highlight it. Answer C, which is calcipotriol, because it is more efficient than Colta. But if the calcipotriol was not there and the other three were there, then of course you are going to go with Colta. Okay, so I hope that was clear. Next one, ECG given QRS widening. She took white tablets from her aunt's bag for suicide. What is the drug? A, digoxin, B, amitriptyline, C, lithium. So what do you think? Okay, there's a question in the previous. Can you repeat why not methylprednisolone? Not methylprednisolone because local steroids are initial treatment. And for systemic treatment, we have some other options. When the local steroids fail, we are going to go with systemic treatment or specific treatment, like I mentioned. Okay, so we are not going to go with methylprednisolone here because of that. Okay, now let's see what you think for as the answer for this one. Okay, so let's see. Okay, most of you think it's answer B or answer A as well. Okay, let's see. So here we have this question is 100% incomplete. First, let me tell you that because we don't have the ECG here. This is just an interpretation of the ECG that has been given. So it's just, we know it's a QRS widening had been there. And the other clue we have is a white tablet from her aunt's bag for suicide. What's the drug? So let's see, we have three drugs. First, we have to figure out whether they can cause QRS widening. Okay, so out of these three drugs, can anybody mention which drugs can cause QRS widening? Let's keep the white tablet aside first. And we have to first figure out which drugs can cause QRS widening out of these three. Can anybody mention? Okay, now it's a like broad question to us. So let me take you to this. So this is like the PubMed article, which gives you the cause for white QRS complex tachycardia actually. Now, we have not been told whether it's a tachycardia or not in the ECG. We have been told only QRS complex. So widening. So here these are the cause for white QRS complexes. So you have a list of causes. Now when you take the drug causes, these are your drugs which can cause white QRS complex. Your tricyclic antidepressants, your amitriptyline, digitalis is there, and cocaine, lithium, diphenhydramine. Lithium is also there. So all three in our answer can cause QRS widening. So all three can be a possible culprit here. So now we have to go through the answers. Now our answer should be solely depending on the color of the tablets. White tablets. Okay. So white tablets, when you take digoxin, actually, yeah, you get white tablets in digoxin. What about amitriptyline? Is it all you get white colored amitriptyline, but is it always white? If you just Google search the amitriptyline tablet, you can see whether it's always white or not. No, you can get like yellow in some regions, because in some region, and you can also get blue colored amitriptyline tablets as well. Okay, it's not always white, but white color amitriptyline tablets are there, not always. So we'll keep it aside. What about lithium? Lithium, yeah, usually it's a white colored tablet. So we are left with digoxin and lithium. Actually, we don't have any other clue here that will tell. Yeah, even amitriptyline is a possibility, because this could have been the white amitriptyline tablet that the aunt has had in her bag. So based on that, actually, amitriptyline becomes least likely, and out of the other two, actually, we don't have a clue in the history to come to a correct answer here. So don't worry, even we can't come to a correct, like, exact answer here based on this one simple sentence here. But in your original exam, you would have had some other clues. For example, they would have told you for what the aunt has been taking the medication. So that would be the best clue in the exam. So they would have told she took white tablets from her aunt, which she was taking for some psychiatric disorder. Then lithium is more likely. From her aunt who is taking for some cardiac disorder, then digoxin becomes more likely. So that would have been there in the original question. So don't worry too much about finding what is the correct answer here. What you have to learn is you should know the causes, drugs which can cause white QRS and white tablets, wise to know. Yeah. Okay. So I hope it was clear. Next one, scenario of vomiting due to molar pregnancy. Sorry, I didn't. Urine ketone positive. What is the next step? Vomiting due to molar pregnancy. There's a question. Do we have to remember the color of the tablets? Actually, it's not possible, right? It's not practically that you can do. It's not something that you can do. They will usually not test you on the color of the tablet. They will give you some additional clue as well. So they will tell you for what the aunt was taking the medication. So it will lead you to the answer. No need to remember the colors as such, because it's not actually possible. So no need to worry about the colors, but just remember the causes. They will usually not test you to that minor detail. Okay, so here most of you think it's answer B. Scenario of vomiting due to molar pregnancy, urine ketone positive. What? Okay, I have a question. So what will this imply actually? Urine ketone positive means, what will it imply? Can anybody mention? Okay, somebody has mentioned can't see the screen. Others, I hope you can see the screen. If everybody can't see the screen, just let me know. Okay, yeah, very good, excellent. Dehydration. Okay, they can see the screen. All right. Dehydration. Urine ketone positive means it tells us that there's a component of dehydration. That's the implication that you have to take. So the next step should be addressing that issue. Okay, so whenever you have a problem, major problem, you have to address it first. So the next step would be giving IV fluids, which should be answer B. So let me highlight it. Answer B, giving IV fluids. Okay. Then you can think of serum electrolytes or something to settle her vomiting. Okay. Moving on, BMI centile chart found to be 95th percentile. Just asking if he is mildly overweight, obese, or normal development. This is a very easy question, but it tests your knowledge on centile charts. Okay, so here there's a bit of confusion here. Okay, mildly overweight, obese, normal. Okay, so there's a confusion between mildly overweight and obese. Let's go through the chart, the Australian chart. This is the actually you can get it from Healthy Kids NSW Government Australia website. This is the NSW BMI age percentile chart. Okay, so here this chart you don't need to like remember the chart or the values, because usually if you are being given a question on the chart, you will be usually given the chart with the values. So no need to worry about these coordinates. What you have to understand is this. Below 5th percentile, it's underweight. 5th to 85th is actually healthy. They consider overweight as 85th percentile to 95th percentile. Now this is for children, all right? This is for pediatric ones. Then well above the healthy, 95th percentile and above, they take it as obese. So this is the category on how they take these centiles. So if it is below, above 95th centile, it's obese actually. 85th to 95th, only they are taking as overweight. Then the rest is normal. So this is the latest one. Okay, so in our question, it's 95th. 95th means it's here in the line. So the answers we have: mildly overweight, obese, normal. Normal development is wrong. We can't say it as mildly overweight, right? So now I saw some of you have mentioned about 97th percentile, about 97th is obese. There had been some sort of a thing like that. But here, even if you take it, if you take it, you can't say this as mildly overweight. Okay, mildly overweight is obviously wrong, but anyway, he's on the line for obese, as according to the chart. So the correct answer here would be answer B, which is obese. So just remember, no need to remember the coordinates. Just remember the percentiles, 5th and 95th as the upper cutoffs, and then 85th to 95th. Okay. I hope it was clear. Nothing much to understand there. All right. Next one. A mass moves with following activity. It has been shown in a picture and has been recent enlargement. No fever, painless. Next step. A, ultrasound. B, ultrasound guided FNAC. C, biopsy. Yes. In the previous one, question 85 to 95 is overweight. Yes, correct. Isn't more than 95 obese? Yes, correct. More than 95 is obese, but 95 is a gray area. But you can't say it as mildly overweight. Mildly overweight means 85, 86, 87, some sort of a thing like that. So it should be like morbidly overweight if it's not mildly. So that term helps you to differentiate overweight from obese, as he is in the 95th line. I hope it was clear. If it's not clear, just ask, I'll explain it again. All right. If overweight given, then we go for it. You will not usually get overweight and obese together in that question, because it's confusing. You will not usually get that. That's why they had given it as mildly overweight. So don't worry about that. The answers in the exam are very clear, not confusing ones. Okay. All right. So here, the answers are varied between answer A, ultrasound, and answer B, ultrasound guided FNAC. See, nobody thought of biopsy here. So let's see, we have a mass that moves with swallowing activity. So this tells us a mass moving with the swallowing activity. They have not mentioned whether this is a midline mass or whether this is a side mass. Okay. So there have been a picture, but we don't know about the picture. So we can't assume that it's midline or sideline. So just we'll go with the information that we have. We have a mass that is moving with swallowing activity. The most likely mass that moves with swallowing activity would be a thyroid one. Our first differential, but we don't know whether this mass is in the midline or in the side of the neck or where. Okay. Even it is not there, the neck, but it had been, let's think as a neck mass and has been recent enlargement. So recent enlargement, assuming that this is a thyroid one, recent enlargement is something for us to worry actually. Some sort of a problem is here. No fever, that tells us it's not an infectious cause or infectious thing. Painless. Painless, again, a sinister thing. Tells us some sort of a problem is there. So painless and recent enlargement makes us think of some problem here. Not something of a benign, some sort of a malignant thing. Okay, so now the question is next step. Okay, they are asking next step. They are not asking the best step or the diagnostic step here. So what would be your next step? So think you have a patient with a neck lump, neck mass. It seems to be moving with swallowing. The patient tells you that it's been enlarged recently and it's not painful as well. Okay, so what will you do next? Yes, next logical step would be doing an ultrasound, right? To see what sort of a mass this is. Now, this we have thought of as a thyroid, but this could not have been a thyroid one. This would have been something else. You are not going to jump to the invasive investigation first. Now, the rule of thumb when you decide on investigations is to go for non-invasive ones first, and then you go for the invasive ones. Now, if they would have asked for what is the best or the diagnostic investigation here, yeah, then you can think of FNAC. But they're asking the next step. So when you are there for that patient, the next step for you would be to check what sort of a lump this is. So whether it's a thyroid or even from the ultrasound, you can get lots of clues, whether it's benign or malignant, even if it's thyroid. So the next step would be doing a scan, which is a very non-invasive one, which will give you a lot of information. Based on that, you are going to decide on whether you are going ahead with FNAC or not. So the FNAC comes after the scan. Okay. So first, the next step here would be answer A, which is ultrasound scan. And biopsy are not going to consider here. That would, all of that, if it is not a thyroid, if it is some sort of other lump, then you are going to go with biopsy. Okay. All right. I hope it was clear. So always pay attention to the keyword, whether it's a next step or whether it's the best step or whether it's the diagnostic step. Always pay attention to this because this can change a lot of things. Okay. So this one. Next. All right. Next question. Man with unilateral breast lump, painful, on spironolactone and digoxin for heart failure. Sister and mother had history of breast cancer. Next step, A, stop spironolactone, B, ultrasound. What do you think we should do? Okay, now while you answer for these, I'll address the questions on previous question. If the picture is thyroid, isn't it FNAC? Even if the picture is thyroid, still the next investigation would be ultrasound. Next question, if they have asked what investigation to aid in diagnostic investigation, then yeah, then you can consider FNAC. It will be the diagnostic investigation. Okay, so here I can see most of you have thought of answer B, ultrasound, but there are few who thought we should go with answer A. So let's see, we have a man with unilateral breast lump, which is painful, on spironolactone and digoxin for heart failure. Sister and mother had history of breast cancer. Next step. Okay, so here we have a case of gynecomastia. Okay, so let's see some more answers. Yes, very good. Answer A and B. Okay, so there's a dilemma between whether it's answer A or B. Okay, so I can see now here we have, this is a case of gynecomastia. All right, so let me take you, sorry, it's not there. All right, so what are the causes for gynecomastia in this patient? Now the answer stops spironolactone because spironolactone is a well-known cause for gynecomastia. So that's one option. Ultrasound, maybe because this here there's a suspicion here because sister and mother had a history of breast cancer. So if somebody is thinking of a breast cancer, maybe to rule that out, they have given the answer ultrasound. So you have to decide whether you are going to stop spironolactone, answer A or B, ultrasound. Okay, now I saw in the chat box, some of you have mentioned it's a painful one. So it should be because of spironolactone and we should stop spironolactone. And in a malignancy, it should be painless. Actually, it's a good thinking. But here, now let's go through this and we have a unilateral breast lump. So unilateral, okay, now let me ask that question from you all. Okay, so can anybody mention those who said answer B, ultrasound, thinking of breast cancer, what are the factors towards breast cancer here? Towards spironolactone, I agree, the pain. Yes, unilateral and the family history, very good. So usually gynecomastia by spironolactone is a bilateral one, usually. So unilateral thing makes us think of a cancer or some sort of other pathology. And family history again makes us this a bit suspicious. And another important thing is there. We'll see whether somebody has mentioned it. Okay, nobody has mentioned it. And him being a man, males have like, they have a prominence to get, yes, very good. Somebody has mentioned it. Prominence to get breast cancer. So him being a man also tells us point towards a breast cancer. But painful, that is the confusion the others had. But still a breast cancer, we usually say it's a painless one. But it can be painful if it is like invading a local cutaneous nerve, or if there are any other associated symptoms. So, okay, you can't always say it's always painless. There's nothing as such in medicine. Okay, so anyway, now we have this seems more like a breast cancer and less like due to spironolactone. Anyway, now here the actions you have for stopping spironolactone and ultrasound. Now stopping spironolactone, now he is taking this for heart failure. You are not going to like go and stop the spironolactone blindly thinking that this gynecomastia is due to spironolactone. That is not a very wise decision to do. And you have enough reasons to suspect a breast cancer as well. So the wise decision, even if you didn't know that this is a cancer, would be to do a scan and to see whether it's a breast lump malignancy or whether it's a benign gynecomastia. And if it's a malignancy, you are going in terms of that and you don't need to stop the spironolactone. If it is due to spironolactone, then you can consider stopping that later if it's not a malignancy. Okay, so the next step, again they ask in the next step here. So here the next step would be, the next logical step actually would be to do the ultrasound scan. Okay. All right, so no questions on that. We'll move on to the next one. A mother takes, yes, clear, all right. A mother takes 8-year daughter to you, okay? Mother got part-time job. Since then, daughter feels unwell when the mom is leaving for work and want the mother to stay at home to company. The girl hasn't gone to school for several days. What to do? A, advise mom to quit the job. B, daughter go to a boarding school. C, liaise with school. D, home tuition. This is a very easy one. I hope all of you will answer this correctly. Yes, correct. Okay, let's see. 8-year-old daughter, mother got a part-time job. Since then, daughter feels unwell, and when mom is leaving for work, want the mother to stay at home for company. So daughter is having some sort of a problem, especially when the mother leaves, she doesn't like it. And the other problem is she hasn't gone to school for several days also. So what to do? Now here there are two problems actually here. One thing is this mother, the daughter doesn't want her mother to leave, and she wants the mothers to stay with her, and she has not gone to school as well. So that may be because of the fear that she would get detached from the mother, but that may be due to something else as well, some sort of abuse going in the school as well. So what are you going to do? Advise mom to quit the job? You can't do that, obviously. Daughter to go to boarding school? Even that you can't do. Home tuition? That's not a very good option here, because it's not the education which is the sole issue here. The child is having other problems as well. So home tuition is not a good option. Liaising with the school would be the next good thing, because you have to talk to the school teacher, liaise with the school teacher or school, and then figure out what's going on actually in this child. And then you are going to do address it next. So here the answer would be answer C, like all of you have said, which is liaising with the school. Okay. Okay. Maybe bullying at school. Yes. Okay, I don't see any questions on that. We'll move on. Next one. About 25-year-old female, admission because of suicide with carbon monoxide. After recovery, admitted to mental health unit and be stable now. Which one is most important to risk assessment? A, without partner. B, unusual dependence to nurse. C, try to break out of the unit. D, manipulative behavior. E, family something, can't remember. Okay, so ignore E. Out of A, B, C, D. Now this is a bit tricky question, not a very straightforward one, but you can work out. See whether you can come to a logical answer here. Okay, so here there seems to be a division of the answers. Some of you think it's answer C, which is trying to break out of the unit. Some for answer D, manipulative behavior. Some for answer A, without partner. Some for answer C as well. No, C we have mentioned. All right, so let's see. Here this question, 25-year-old female is there. And she has been admitted because of suicide with carbon monoxide. Okay. After recovery, admitted to mental health unit and be stable now. Which one is the most important to risk assessment? Okay, now suicide risk assessment is also a very important topic. Now this I have actually taken it from the suicide risk assessment, and it's actually Australian suicide risk assessment tool. There's a separate suicide risk assessment PDF, which I'm not going to take you there now. It tells you like how to assess the suicide risk, like how to categorize them as high risk, low risk, and what you are going to do likewise. So I don't think you need that bit of a huge information, but this table is very important. That's why I have put this table here. Now this tells